we all are here. And this is a really good opportunity, Dr. Ta. I am thankful to you for inviting and keeping this in a workshop. So, this is my technique. So I'll a little bit elaborate. Before this technique, I'll go to some basics. This is being a workshop, but vitiligo is a very common problem, and you people must see this. Is 2 to 4% of OPD patients daily. And this is basically a cosmetic problem, and there are many people who are suffering psychologically. So coming to vitiligo, it's derived from vitilium. That means damage. It is acquired hypomelanotic condition. Is from the progressive. I will not go on this. You all know what is vitiligo, I think. So, skipping this epidemiology as well. Regarding the etiopathogenesis, because if I skip, then what I am going to I have to tell something. It's a being a multifactorial disease. Has a relationship with both genetic and acquired factors. The most important theory is autoimmune. Another theory is neurohormonal hypothesis, oxidative stress, and cytolytic theory. These are the few important theories for the genesis of vitiligo. This is the important part of vitiligo surgery. Because as far as I know, it was, and then there was a modification. Suction blister was introduced by Falabella in 1971 and punch graft by Orientate in 72, mini crunch by Falabella again, and cultured melanocyte and the grafting of cultured non-cultured epidermal cell suspension. That is also important aspect of this. And the Jodhpur technique was discovered in 2007. The principles of vitiligo is to introduce the melanocyte into the lesional skin. Basically, we are supposed to introduce the melanocyte at the site where there is no melanocytes. So there are few important factors. The cell should survive and this should function normally functioning normally. One of the best technique, and that suits to the patient as well. So types of grafting, there are tissue grafts and cellular grafts. Tissue graft, as the name indicates, it contains the whole skin, basically a melanocyte or separated melanocytes and separated keratinocytes. So that in tissue grafts, the mini puncture graft, suction laser graft, thin split thickness grafting, hair follicle graft, smash graft, these are the basically grafts which are included in tissue graft. Then a cellular graft, non-cultured cell suspension, epidermal cell and a follicular cell. Cultured melanocyte, keratinocyte graft, cultured epidermal cell graft, non-cultured follicular root sheath suspension graft. This is the new graft technique. And the Jodhpur technique comes in between. Basically, this is in between the cellular as well and the tissue graft. What a facility one should develop during the surgery, and you must be equipped with all the emergency measures as well. Generally, general anesthesia is not given, but it may require some time, and in case wherever the general anesthesia is needed, you have to be all ICU facilities and anesthesiologist. There are so many things which you need with a general anesthesia. And for that, you need a complete, a full OT, not a minor OT. The selection of patients, it depends on the stability of the lesion. Stability is basically, by IADL, it defines as a 1 year stable. It should not be progressive. It should be stable, no new lesion, plus it should be stable at the site, no expansion of the margins of the lesion. So this is the stability. For testing the stability, you can do a test grafting as well. Cobnus phenomena, no recent Cobnus phenomena should be there. Longevity of stability and disease versus regional stability, these are the few factors which sometimes we may consider it before. Because disease sometimes, whenever a patient who is in hurry, especially whenever there's some marriage or important function of a patient finalizes, then he comes to you, doctor, मेरा तो 3 महीने बाद शादी है, 2 महीने बाद शादी है. This is a small patch on my face and I want to get rid of this. So ऐसे cases में we have to, at least sometime, not always, but we have to consider the patient's importance of the time as well. In these cases, in this scenario, we have sometimes we have to skip that. The stability of overall, because you are not supposed to do in an unstable patient. In the of the lesional stability, lesion का stability plus उस lesion का stability, not a generalized. If it is a generalized, then sometimes you cannot do, but if you are considering lesional, and there are few papers about this, lesional and regional stability of a vitiligo, and these are also important factors where you can consider for the vitiligo graft. This I told you, 1 year stability, and clinical stable lesion has a well-defined, sometimes pigmented border shows spotty pigmentation, while an unstable has an ill-defined border. These are few points that you have to consider, because sometimes patient भी आपको झूठ बोल के वो सर्जरी करा देता है. So these are the important चीजें जो आपको भी clinically you people should know that how the patient जो बोल रहा है वो सही बोल रहा है कि नहीं है, whether the lesion is stable or not. Is it really stable, or patient just want to get rid of this by getting the surgery done? So these are the things you must know this. And cellular stability markers such as CD8 and CD45RO and FOXP3 prove useful indicating the stability of lesion. These are the basically theoretical one more. Clinically, I told you, and a history wise also. how to perform test grafting. The original test was proposed by Bella. Patient is selected with a stable vitiligo who may respond to melanocyte transplant, and the test was considered positive if unequivocal repigmentation took place beyond 1 mm of the border of the implanted graft over a period of 3 months. Whatever kind of surgery you go to do, you just go for a test patch, and if there is a repigmentation of 1 millimeter, then it is considered as a positive. And this is a gold standard for establishing the stability of a lesion. The different beta scores. So, coming directly to the pre-operative workup, counseling and informed consent. हमेशा ये चीज हमेशा ध्यान रखना. Don't assure patient 100% that you are giving 100% result in a vitiligo patient after 3 months or 6 months. It basically varies from person to person, technique to technique. Even with if person is using one technique and another is using the same technique, then the personal variation is also there, and you know how patient behave. So जैसे अपन कॉस्मेटिक में देते हैं, नेवर पेशेंट का सबसे पहले ओवर एक्सपेक्टेशन जो है, यू आर सपोज टू किल दैट एंड यू जस्ट से I will try my level best, these are the technique, will give you the result, but I cannot assure 100% you are going to have the result. I will try my level best and hopefully you will get the pigmentation, but right now I can't say how much you are going to get the pigmentation. और होता भी है, also tell the patient that there are chances कि उसमें आपका you are responding very poor to the surgery. तो पेशेंट हमेशा उसकी ओवर एक्सपेक्टेशन किल करना होता है. दिस इज वेरी इंपॉर्टेंट एंड you have to go through the systemic and cutaneous examination, routine investigation like CBC, BTCT and sugar, and if patient, if you are going for the general anesthesia, then the anesthesiologist will tell you what are the different investigation you need. A detailed consent, explaining each and everything to the patient. And I told you the counseling part first. So, Dr. Munesh, are you going to tell about the mini graft also? You are expert of mini graft?
No, sir. I'm going to only talk of cell transplant, sir.
Okay. So, little bit I am going to cover the mini graft as well.
Yes, sir.
The principle is melanocytes have been shown to spread centrifugally from the infundibulum to the hair follicle to the basal layer and recolonize the epidermis with the active and functional melanocytes. So in turn will giving the color to the depigmented skin. So these are the different punches. You can see the tight, loose and disposable punches. We prefer disposable punches. In vitiligo cases, you have to select two areas. One is a donor area, another is a recipient area. Recipient area is obviously where you want to get the pigmentation, and the donor, most of the time, it is the lateral portion of thigh or gluteal region, and it may be the post-auricular area in a case whenever there is a recipient area is on face. Punch impressions are made very close to each other. Recipient site prepared earlier than the donor area. Initial recipient chamber may be very close to border of the lesion to reduce the chances of perigraft halo. This is very important, otherwise you are going to give perihallograft. And these chambers are spaced at a gap of 5 to 10 mm. The same size punch is used for both recipient and donor area, except if recipient site is on convex surface, example neck, and then a smaller punch is used for better fit. Nowadays people are doing, I think Munish is also doing a mega punch, mini punch session.
No, sir.
No, we are
I
not doing.
did a no. This was complication.
Anyway, nowadays,
I removed the punches for this session.
yeah, these are the basically the worst part of the punch grafting, because this gives a goggle is turning and this doesn't look good, and even you can see a very punch hello as well. So ये सबसे बड़ा है Munish. This is a photograph from you. Munish is depicted here as well. This you have given me the time of ACS textbook. There is a chapter in ACSI textbook of dermatology surgery and vitiligo. I covered all vitiligo in that. And this is a 1 hour lecture. And these are the slides from that lecture also. I had mentioned your name here as well.
Thank you, sir.
So, these are few surgical pulse. Basically, I don't do this mini punch. My bread and butter is a Jodhpur technique and its modification, which are really interesting, and you people will love this. But being a workshop, so I just mentioned a little bit about the punch. Surgical pulse, the size of punch, smaller the size, better the result, and always keep a distance of 5 mm between two grafts. Don't overcrowd the recipient area with so many of grafts. Use thinner graft.
I am in confidence.
So that it will stick well to the recipient side. And if you are using a thicker graft, then it will pop up. So the more chances of developing the cobalt-stone. Same size is good, but on convex, as I told you, little bit smaller size will be better. And use a silicone dressing or any compressive dressing, that will be better. So this is basically about how to select a patient and how to perform the a vitiligo surgery. These are the basic principles. Now I am coming to the Jodhpur technique. Basically, Jodhpur technique, as the name suggests, this was invented by me only. And how I invented this is basically a very small idea when in 90s when I was doing when it hits this epidermis, it breaks the epidermis into smaller pieces, and a few more pieces they were stacking, they were on my face. So at that time I thought that if I could collect these pieces, because these are the pieces with the melanocytes, the broken parts of skin, they contain the melanocytes. So I thought whether if I can collect these broken pieces of skin, then these can be used as a graft. So this was the idea. I worked on this idea for many years consistently, and I got many failures as well, but finally succeeded. So that is how this Jodhpur technique came. Not only this, I am happy with this. I am doing also modifications in Jodhpur technique as well, and that has been accepted. That has been published in a JAD as well. So it's basically my whole idea is to surgery should be like that. Anybody can perform. For that, nobody is, because during your MD time, it's very difficult to get out from department for learning or doing some fellowship for this vitiligo surgery or any kind of thing. Even after that, it's very difficult for a MD, the fresh MD student, to go and learn. So my idea is, if you can see this seriously, if you can watch this technique, I am 100% sure that you are going to start from tomorrow onwards. This is so simple. So, I told you all about this. So, Jodhpur technique is a unique method where donor area is dermabraided. Here we are not supposed to take any graft, a split thickness graft. You are supposed to dermabrade the skin, and this dermabraided skin, as I told you in the introduction as well, the idea came. So you are supposed to collect the dermabraided skin. Donor area needed for collecting grafting material is approximately 1/3 of the recipient area. It's a very simple, very effective and extremely low cost. सिर्फ आइडिया का ही कॉस्ट है और कुछ भी नहीं है इसमें. In a simplified term, it is autologous, non-cultured, non-trypsinized, keratinocyte, melanocyte, cellular graft technique. Indications, this stable vitiligo वो तो है ही है. इसके साथ along with this, I also use this technique in a chronic non-healing ulcer. And is found to be very effective for this non-healing ulcer as well. I'll show a video of this. Procedure at recipient site. The site is prepared in the same way as we are doing in all vitiligo surgery. You have to take all septic precautions and under local anesthesia, that is lignocaine 2%. You apply a ring block or a square block, and in this technique, what I prefer to dermabrade the recipient area first. Because if you are dermabraiding the recipient area first, then by that put over there and now come to the donor area. Donor area is dermabraided till the fine bleeding points are seen. But before dermabraiding, the donor motor, when hit the skin, it breaks. Ointment will entangle all the particles, so the things will be ready as a paste for a graft. So this is how you are supposed to do. After preparing, first you are supposed to prepare the recipient side and then apply, then go for the donor area, apply a thin film of ointment. Use a micromotor and then you can see this is the pigmentation. Here you can see
this is a family affair, more or less.
Pointer. you applied a thin film of ointment. Can you see this is a ring block over here? The derma is done, and now you can see this is a paste-like material is collected near the donor area, and this is to be collected, and this is our graft. This is showing you the details of good technique. Here I am injecting local anesthesia, and after local anesthesia I am preparing the derma, I am preparing the recipient site by dermabrasion. And now I am switching to the donor area. Now you can see now donor area ring block is there, the square block. Okay, now I am applying. Thin film of ointment. And dermabrasion at a slower RPM. RPM is around 4 to 5,000. And this is how you can see
नीति को नहीं आ लग रहा was supposed to come. ये बात की थी बुलाएंगे दिल्ली में मेरा प्रोग्राम है बोले तो उसको पहले चले जाइए आज आके आगे चले जाइए बोला हम आएंगे.
So this you can see I am injecting local anesthesia at the recipient site. You can see this पहले से सर्जरी किया हुआ था. This is stuck on STD and I am doing dermabrasion of a recipient site. You can see the fine minute pinpoint bleeding, and now switching to the video. गलती से दूसरा आ गया. This was a 6-minute video and it has been in some presentation. Anyway, you can see after applying a thin film of ointment, I am dermabrating, and you can see the graft material is being collected nearby your face, and you have to collect it in a spatula, and this is the graft. Very simple. This is very simple technique, and this as a whole you can more homogeneous, and then you can also apply. So there are different ways how to apply. Spread this over the recipient side, and after spreading, just apply a collagen dressing and then a cotton wash, and you dress it for the 7 days. These are the and as you can see, extensive vitiligo. All the eyes and everything is here in the this patient in multiple settings. can see this. More than 90%. This one, eyelid covered, and all this. So this is how the Jodhpur technique works. And you can see there is no hyperpigmentation as well. It's best suited for the face. And a very cheap. कोई इसमें कुछ भी नहीं है. Just you have to dermabrate, collect the graft, and spread it to the recipient side. And put a collagen dressing, all dress, then leave it for 7 days. This is so simple. It's basically very simple technique. Anybody can do it. And results are, I compared the Jodhpur technique with the STG. You can see the stuck-on appearance of this STG, and the whole is much covered. And here with the Jodhpur technique, you can see excellent results. These are again a few cases, so I'll not elaborate because I have got very long list of cases and more than 20 articles on Jodhpur technique and its modification. So far I had published in all reputed journals. And now coming to the very simple technique, one more technique. This is the modification of Jodhpur technique. Here, till now, what we were doing, we were selecting two areas. One is the recipient, another is the donor area. Donor area is usually the gluteal area or lateral aspect of thigh. And recipient area wherever it is needed. Now I combine both the areas. So what I did is, I just took the perilesional skin of any vitiligo area, and that perilesional graft I used as a vitiligo graft for that particular lesion. The vitiligo has a transient hypermelanosis. This is very useful for this. This was explored by Takayama to find that the degranulated mast cells were found in 30% of the vitiliginous patches. So the milieu has been increased melanocyte expression of C-kit lesion in the study. So this helps in a better pigmentation of a vitiligo skin. So that is why I use this perilesional skin as a graft. The recipient side is prepared as we are doing other techniques. For skin surround along with the recipient dermabrasion. And then surrounding area is dermabrated till the perilesional skin appears whitish. And graft is visualized as a paste. This is what I have shown you. I am showing you a picture of this, video of this also. Perilesional halo, you can imagine that how the morbidity of a vitiligo patient has, I try to reduce by 2 sides coming to one side, not only more. Basically, what happens when if you are treating a face and if you are taking the non-sun exposed from the thigh, then they are more, they are certainly to give the hyperpigmentation. For that you are supposed to give sunscreens and all others. So here in this perilesional, we are taking the same skin from the same lesion. So not only morbidity, time, you are also getting a better results in this time. This time. These are a few steps. I think it is clear, but still I am one more time so that you people can start from tomorrow onwards. this is the perilesional halo of a previously treated vitiligo patch. Here I am dermabraiding this. And then after dermabrasion, I am just applying ointment. You can see this. And after this, this is a graph of a perilesional stain. Here you can see the graph, and here you can see the perilesional skin. Not only the perilesional, vitiligo area as well as perilesional. Both here you can see. And here you can see the graph. This is basically graph on a slide, then homogenizing, and then finally applying. So this is basically very simple, very easy, and advantages I told you. These are a few pictures. You can see the changes before, after. This is another modification of Jodhpur technique. So this is basically whenever you are taking a suction blister graft technique, you always take it from the donor area, because you are supposed to apply it over the recipient area. But here what I am doing is, I am doing at the recipient side. De-roof the vesicle and then put this graft inside the suction blister area. So this is again a modification of recipient site in a Jodhpur technique. A new modification of recipient site is a blister formation. A blister is made on a recipient, the paste-like material which contains the melanocyte and keratinocyte was transferred into the pocket created at a blister site. So you remove all the exudate from the blister and put your graft by creating a pocket at a blister site. And this, the roof of blister placed over graft will act as a biological dressing and shall protect the transferred material from spreading outside. This is simple, but it is very useful. This is how the blister is being made. You all, those who are aware of the blistering, how to take this is basically recipient side. Here I raise it, and the bulla is formed. Now this. These are the different pictures of the same. And you can see the area which is covered by this. That is post-operative photograph of this after 3 months of this. And this blister technique is very good for the areas where you have linear LB candice is there. Where all other technique you cannot do, but this blistering along with the with those leaks, and these ulcers are very difficult to heal, whatever the etiology it is. So, in this technique, marginal dermabrasion was done at the ulcer with a pinpoint bleeding. And this is going to be the end point of your dermabrasion. And the epidermal particles, epidermal graft, which I just shown you in a Jodhpur technique how we take from the lateral aspect of thigh. The similar way we are supposed to take it from the thigh and then spread it over the margins as well as over the ulcer. See in this picture. Again a small video. And I'm denuding the ulcer and the Jodhpur technique graft as we are doing in other methods, the same technique. Lower RPM, apply a thin film of ointment and then dermabrade, and the paste-like material is collected near the dermabrasion site, and this is to be collected and spread over the ulcer site. How it gives result is also have been published in some international cognitive index. Really wonderful technique, especially for non-healing persons. Non-healing ulcers, chronic, even I treated with this technique a 12-year-old non-healing ulcer with this Jodhpur technique. There are some references you can see. And for further reading, I will recommend you this Dr. Satish Sawant's textbook of dermatosurgery and cosmetology, and ACSI textbook with the chapters, but I think the penicillin is not there, so I updated in ACSI, and in Dr. Vineet Laland textbook of comprehensive textbook of Vitiligo, it is updated with even with the non-healing, penicillin, everything. But here in Dr. S.S. Sawant's book, it is only the Jodhpur technique. But he elaborated in a way, if you don't understand anything, if you have any query, that query will be shown in your Dr. Sawant's book, or I will be available, I can answer your queries. But I want you people to start dermatosurgery. And in a dermatosurgery, I will like, and I will love to see you doing vitiligo surgery, and my best wishes for you. Thank you.
Thank you, Dr. Dilip. I think most of you have learned at least something from here. The PGTs, to become full-fledged MDs, you'll be starting the job. Now, I request to sit on the chair. They're better, you can see from there only. They are coming. And I request Dr. Manish Paul to come up on the stage and start teaching our PGTs. Please sit down. And Dr. Niti Kungar will come and sit on the dais. You can see from here. There's a.
It's fine here.
Okay.
ठीक है और वेल क्या है
afternoon, friends. So this is a video workshop. So I'm not going to present. Try to just move on to some slides. And so this is how the basic OT setup is. So we do a lot of procedures under general anesthesia with vitiligo surgery. Drugs. We have the centrifuge machine, the drums, and this is the basic layout for the vitiligo surgery. And these are the instruments: drum vibrator, birds, blade, and all things autoclaved over there. This is the carpet we have. This is the incubator, which is again placed inside the OT only. This has the tray which we use for cell separation, which is airflow. So you try to the CO2 laser there. Formalin box with the instruments which cannot be heated. So that kind of gives you the bird's eye view of the setup you need. So the point is, whenever you're doing any type of vitiligo surgery, it should be done in a proper OT setup, not a makeshift place. Sterilization is very essential, so that is important. So the first step of the surgery is that you have to take a graft. So the graft is typically taken from the lateral aspect of the thigh. You can use various instruments to do it. The graft has to be ultra thin. How do you do it is ultra thin? If you look carefully, it is not even bleeding. And when you place the graft in a saline, it should float. It should not curl. If the graft is curling inwards, that means there's a lot of dermis inside it. And if there's dermis inside it, that means you're not going to achieve cell separation. So if you can see, there's just a little bit of capillary bleed, otherwise there is no bleed. Once you have taken the skin sample, so this is the skin graft that we have taken. Then you wash it with normal saline so that there should be no blood, because blood can inhibit, stop the action of blood over there. And in this petri dish out here, you can see we have trypsin. So we are using trypsin EDTA solution. It's available commercially, or you can make it yourself also. Again, as Dr. Dilip mentioned, in the ACSI textbook also there are details of the type of trypsin that you have to use. You have to put the graft at the trypsin. And you have to tease it, and you have to spread it. Earlier the thought used to be that the dermis has to face downwards, but of late we have realized that it doesn't really matter whether the epidermis is up or the dermis is up, it is the same thing. It doesn't really matter. The important thing is that you need to soak up the thing. And typically you need 5 ml of trypsin for a small area that you are operating. It comes as frozen. So most important thing is to learn how to harvest ultra thin grafts. And if you see here, the grafts are curling up a bit, so but the center is flat, so the graft ideally should not. So once you have done it, then you have to tease you neutralize the trypsin. You can just do it with DMEM media, or you can use rendolactate, or you can use PDS. Yes, there are multiple choices which are available, and you tease it, and you will see lives that the skin separates. You can see the dermis, which is the white portion over here, which is separating epidermis. So this is what we are trying to do. you have to scrape the dermis and the epidermis so that you can collect this whole suspension. Further continuing, you can see now that we have been able to separate out the dermis which is on my hand and the rest of the epidermis. Now this epidermis still has the 4 layers which we need to further separate out. So you basically need the stratum basale and the stratum glandulosum. You don't need the rest of it. So you have to take it out and you put it in a sterile test tube and you have to centrifuge. So this is just to show that you will
सर का फोटो लिया भैया सर का फोटो लिया
is that you get this pellet which settles at the bottom of the tube. So this is what we are interested in. We'll take it out and the base is what we need. This is melanocyte keratinocyte cell suspension. This is not purely melanocyte keratinocytes. They are like friends or like their family. So what we realize is the transfer, if it is together, their chances of survival are better. In any case, unless you're doing a culture, you can't really isolate the melanocytes and grow them. So once this suspension is ready, then you vitiligo. Patient is sedated. So we do a lot of work, as I mentioned, under IV sedation. So we do what is known as giga sessions. Also, we do 300, 500 centimeters square in one go. So the patient is not intubated, if you can see, but she's on IV sedation, and I'm using dermabrating the wheels. If you realize, my right hand is holding the handpiece, and my left hand finger is the one which is controlling. It's a very smooth movement, and if you realize again, there's hardly any bleed. Can you appreciate that? The level of your dermabrasion has to be very perfect, because you don't want it to have a deeper bleed. The skin has been demineralized, but there is no bleed. This is the level of dermabrasion try to achieve. And you have to do it uniformly. There should be no skip zones. If there are any skip zones and if you transplant the cells, those areas will not take up. So if sometimes your vision on that area, when you are doing areas like the eyelid, you have to be careful unless your hand is quite settled with a dermabrasion will always show. So you ought to be careful also. Bleed is coming up, so this is just a little ooze